today and talk to you about vasculitis and COVID vaccine and vaccination in general. Before I start my talk, just a brief introduction about our immune system. So our immune system has 3 essential functions, and the first one is defending us against foreign microorganisms such as bacteria, viruses, autointolerance, recognizing our own cells and tissue, and then immune surveillance, just recognizing old and damaged cells and getting rid of them. We have 2 pathways. We have the innate immunity and adaptive immune system. They are a little bit different. The first defense line is the innate immunity, and this is a little bit non-specific system, does not create memory and help us for the future, but is the first defense line. And then we have the adaptive immunity, which consists of like major 2 cells. They are called T lymphocytes and B lymphocytes. And this is something very, very specific, and it does help us in creating memory for the future, and it plays a very significant role in vaccine response. We're supposed to have a balanced immune system, but sometimes due to genetic cause or acquired cause, sometimes things goes wrong and it leads to overactivation of the immune system, leading to having allergic reaction or autoimmune disorder, or leading to under-reaction and activation, and this will lead to being predisposed for infection, malignancy, and poor vaccine response. Per the CDC, 3% of the general population are immunocompromised, and this include cancer patient undergoing chemotherapy, bone transplant patient, solid organ transplant, and our immunosuppressed patient, anyone on steroid 20 milligram or more, anyone taking any immunosuppressant medication, including methotrexate, azathioprine, rituximab, etc. So to treat vasculitis, we have so many medication, and some of them, they target the innate immune system, and some of them, they target the adaptive immunity, and such as rituximab, which mainly inhibits the B-cell depletion. What's common among all of them, they are all immunosuppressant, which means they do increase the risk for infection, including bacterial infection, viral infection, and fungal infection. And each one of these drugs, they may predispose to specific infection. And that's why before we start our patients with autoimmune disorders, we try to screen for infections such as hepatitis and tuberculosis, and we make sure they are vaccinated before we start our treatment. So we're going to talk about the 2022 ACR, American College of Rheumatology, general guidelines for vaccination, and then the last part of the talk will be about COVID vaccine. So American College of Rheumatology released guidelines in 2022 about what kind of vaccination our patient with rheumatic disease they are supposed to get. And the reason why, because they are at increased incidence and risk for having severe infection due to the immunosuppressant they take and because of the poor vaccine response. The panel consisted of 41 individuals. Most of them, they were physicians, including infectious disease doctor and rheumatologist, and we had few patients and even ACR members. The goal was to identify what kind of vaccine they are supposed to do, what are we supposed to do with the medication, the timing of the vaccine, and also what about the disease. So for instance, for influenza vaccine, the ACR guidelines recommended the influenza vaccine for every adult, immunocompromised adult, and they recommended the higher doses of the influenza vaccine over the regular dose. And this is based on 2 trials in rheumatoid arthritis patient where we had the patient, they did have better vaccine response and better coverage with the higher doses, but still sometimes we may struggle with insurance coverage with the higher doses. So regular dose is absolutely better than no vaccine. What are we supposed to do with the medication? We're supposed to hold the methotrexate. If someone taking the methotrexate, we're supposed to hold it for 2 weeks after the vaccine. And if we could do the vaccination prior to initiating any medication. If someone is already on rituximab, then we have to delay the infusion for a few weeks after the vaccination. it's better to give the vaccination before we start rituximab if possible. Sometimes it's not that possible. The disease is very severely active, so we have to give the vaccine and start the infusion. And it's okay to give the influenza vaccine if someone is taking prednisone 20 milligram per day or higher. The same thing for the pneumococcal vaccine. It's recommended for any adult patient on immunosuppressant. And the standard right now is a new pneumococcal vaccine 20. But if you have received any kind of pneumococcal vaccine in the past, we have also guidelines, what are we supposed to do in time as well. The new shingles vaccine also is very, very effective in order to protect our immunocompromised patient and with very minimal risk for disease flare after taking the vaccine. This table summarizes what are we supposed to do in terms of medication when we are taking the non-live attenuated vaccine versus live. For the non-live attenuated vaccine, it's okay, most of the time we continue the medication and we give the vaccine, but for the live attenuated vaccine, then most of the time we ask our patient to hold the medication for a few weeks prior and a few weeks after the vaccinations. And then now we're gonna move to the COVID-19 pandemic, and this is very overwhelming, and this is very sad memory for all of us, for patients, for physicians. We were overwhelmed, and obviously we were not ready in the beginning. We lost a lot of our patients, a lot of family members and friends. And it was also overwhelming for the physician in the beginning because a lot of the symptoms of the COVID infection, they were kind of similar to our patient with autoimmune disease and vasculitis. And even we have a few case reports about de novo vasculitis after the COVID infection. The early report from the COVID-19 Global Rheumatology Alliance, and this is an international effort, reported almost 1,200 patients. Many of them, they did have different forms of primary systemic vasculitis, and some of them did have polymyalgia rheumatica as well. Most of the cases were reported from Europe and then from United States. Only 36 of the patients, they were in remission. 47% they were not receiving any treatment, and 36% they were on rituximab at the time when they reported the cases of COVID infection. Overall, among 1,000 patients, we had 50% hospitalization, 11.2 hospitalized without any oxygen, 23% they were on oxygen, and we have 15% death rate. And among different forms of vasculitis, ANCA-associated vasculitis patient, they had the worst outcome among other forms of vasculitis, with death rate of almost 22%. 37% they were not admitted, and we have 10% they were admitted without any oxygen, and 30% they were admitted and requiring supplemental oxygen. And then followed by giant cell arteritis patient in terms of the outcome. For ANCA-associated vasculitis, the poor prognostic factor, there were use of the rituximab and cyclophosphamide at the time of the COVID infection, severe active disease, and for giant cell arteritis, older age, obesity versus to non-obesity. But we can say that this, the previous report was done between March of 2020 and December of 2021, and we can say that, okay, most of these patients, they were not vaccinated. They were not vaccinated. This is prior to the vaccine. What about after vaccination? And this is another study looking at the vulnerable patient, and our patient was on rituximab. They were included in the group 2. And some of them, they were not vaccinated. Some of them received 1 dose, 2 doses, or 3 doses of the vaccination. And still, a lot of them, they were admitted despite vaccination. So immediately, the CDC, the Center for Disease Control and Prevention, classified our patient in the higher risk category, in addition to older age, medical comorbidities, and unvaccinated patient, comparing to other patients. So we can say that COVID-19 pandemic is not over, specifically for our immunocompromised patient. Up until May of 2023, the WHO was reporting almost 100,000 cases on weekly basis. And of course, we don't have so much data because the emergency was ended. But still, we are facing COVID, and I don't think it's over yet. So we have still to be prepared. How can we prevent it? And I think the most important two things we can say is a vaccination and still masking. And I know it's not that convenient to ask everyone to mask for the rest of their entire life because they are on immunosuppressant medication, but when we say that, we're saying just it for the patient's sake, right? Like, you can take it or leave it, but we still, at least, we are recommending it in the huge crowd when someone is traveling indoor. So it's something, and for anyone on any immunosuppressant medication, but specifically anyone on rituximab or mycophenolate mofetil. And this is a controversy about the vaccination, right? So what we agree about, I think most of us, that vaccination, COVID-19 vaccination is recommended for any immunosuppressed patient. There is no absolute contraindication for the vaccination, except if you had a true allergy to one component of the vaccine. If you are not vaccinated, then it's better to talk to your doctor. If you have not received any dose of the bivalent vaccine, you should talk to your doctor about it. It does cover for the new variant comparing to the monovalent vaccine, which is only covering for the primary variant for the initial one. Now, for the immunocompromised patient, it's recommended to get the boosters, right? And the recommendation from the CDC and the FDA to get the booster every 4 to 6 months for immunocompromised patient. And if they didn't have any recent COVID infection. Now, the uncertainty is about like how many of them we're gonna get. If you are saying every 4 to 6 months, is there any limit number? And unfortunate, until this time, there is no limit. It's a discussion between the provider and the patient. But we are still encouraging our rituximab patient to get it prior to their infusion, like few weeks prior to the infusion, at least like every 6 months if possible. There is probable a little bit of risk of disease flare, but still, as a physician, we think that the benefit of the vaccine outweighed the risk of disease flare. So we do encourage getting the vaccine and the boosters. And we know that the vaccine is very effective, and we're talking here about the primary series and the booster, is very effective in preventing severe infection, hospitalization, and reducing death rate. And it is effective in our immunosuppressed patient. However, we are seeing breakthrough infection, right? And this is a study was from our group at Cleveland Clinic, looked at 1,600 patients on rituximab, and we had 74 breakthrough infection. And most of these patients, they were vaccinated. 27% had vasculitis, and 46% they were on rituximab for more than 3 years. And the outcome was not very encouraging. 39% they were hospitalized, 14% in critical care unit, and 8% death rate. So our patient on rituximab, they are still very vulnerable at increased risk for having COVID infection despite the vaccination, so we have to be careful. So what can we do in addition to the vaccination? We have the monoclonal antibodies, right? And it was indicated for someone probably they did not respond to the vaccine very well, and someone they are at increased risk for COVID infection. So the primary report about it was very effective in reducing the number of cases of COVID infection at 6 months and even initially. And this is another report from our group about the effectiveness of UV shield. And they reported only 2% of breakthrough COVID cases and almost 400 cases of patients on rituximab. So it was very promising to us. However, the excitement did not last too long, and the reason because the virus kept changing. So now there is a hope that there is ongoing trial looking at another monoclonal antibodies, and hopefully we will hear about it in the near future. What about treatment? I mean, I think the first step in terms of treatment is early testing. You know how to get testing right away. You think whenever you get symptom and you think, okay, it could be COVID or it could be flu, it could be infection, get tested right away. And we will talk later on why it's important. You know how to contact, keep some home testing at home. If you are exposed but you're not having any symptoms, we may ask you to hold your medication for 2 weeks probably if your disease is in remission. If you are on rituximab, we may delay your infusion for a few weeks. Again, if your disease is well controlled. If you are having infection, then most likely we will hold your medication for a few weeks. But of course, you have to discuss with your primary doctor. We are fortunate to have like 3 antiviral medication. 2 of them, they are oral, and 1 of them is intravenous infusion. And 3 of them, they are very effective in reducing the viral load and by suppressing and by inhibiting the enzyme responsible about virus replication. We have like 5 to 15% of rebound disease after treatment, and we have potential drug-to-drug interaction with other drugs, so we may ask you to hold your other medication while you are taking the antiviral medicine. This figure summarizes who are eligible for outpatient COVID-19 therapy, anyone 65 and older, anyone immunocompromised, multiple medical comorbidities, age 50, and unvaccinated. And the reason why I said get tested immediately, because if you are getting tested within 3 days and of the onset of your symptoms, then you're going to be eligible for having the oral antiviral medication if you have a normal kidney function and liver function. If not, then we might need to give you the intravenous medication. And even if you waited longer, then you might not be eligible for taking that drug. For inpatient, and I don't wish it for anyone, if they are requiring oxygen or any intensive care, we have also other options, and this is to control the overwhelming inflammation, and this includes some of the medication, another version of prednisone of steroid, and then some of them antiviral medication and another biologic therapy. So we can say the emergency is over, but the COVID pandemic and COVID infection is not over. Vaccinations are recommended for all immunocompromised patients given increased risk for infection and poor vaccine response, if possible, prior to initiating immunosuppressant medication. COVID-19 boosters should be considered every 4 to 6 months, specifically for patients on rituximab and probably mycophenolate mofetil. Early testing and treatment are essential for better outcomes. Thank you.
That was a great talk. Thank you so much, Kenana. So we're going to start taking questions from the folks in the room and also from online. Keep in mind, this is a general recommendation, so each case, individual case might differ. And sometimes, for example, when Dr. Yassin mentioned that the recommendation is to hold the methotrexate 2 doses after the vaccine, it might not apply to everyone. So it depends what the situation is with the disease, the medication. So we might not be able to answer any specific questions, but we'll try our best. All right. Is it recommended to pause treatment prior to getting the COVID-19 bivalent vaccine or boosters?
Not prior. If someone is on rituximab, then we may delay the infusion for probably 2 weeks or 4 weeks if their disease is well controlled. For other medication, I mean, sometimes it's the same thing for influenza vaccine. If they are on methotrexate, not prior, but after, I may say, okay, just like hold your medication after the vaccination for 2 weeks if your disease is well controlled. If they wish, there is no specific guidelines about other medication, but if their disease is well controlled, then I would say yes for other medicine.
Okay, we have a good question here. Can I get the pneumococcal vaccine plus the COVID vaccine at the same time, 2 weeks prior to the infusion? And I'm assuming it's rituximab. So that's a common question we get.
I think initially we were afraid to give like 2 vaccinations on the same day, but afterwards, I think the guidelines okayed that. Regarding the infusion, I would try to give it probably 4 weeks prior to the infusion. Not I think 2 weeks is a little bit closer to the infusion, so like probably 4 weeks. Of course, everything depends on the disease status.
So can we become resistant to Paxlovid?
What did you say? I'm sorry.
So the question is lack of response because you've used Paxlovid before. That's, I think that's what they're trying to ask.
I'm not aware about that. I can't comment on the rebound. It's reported 5 to 15 where like, okay, you finish your Paxlovid and like some of the symptoms come back. For healthy individual, I think there is no indication to restart the antiviral medication. But for the immunocompromised patient, it's controversy, and some of the experts, they may consider 5 days of the Paxlovid of antiviral medication again. But this is again controversy, and we don't have, it's not studied, so.
So I think that in addition to that, maybe the question was regarding if you get COVID a second time and you want to, and you were prescribed Paxlovid maybe later, and so there is no contraindication to do it again. So let's say someone got COVID now and 6 months later got it again, they'll be prescribed Paxlovid again.
Mm-hmm.
Good question. Do you wait to get the vaccine, the COVID vaccine, after you have had COVID? And if so, is there any recommendations to how long to wait?
It's usually, I think, for 3 to 4 months after COVID infection. And the reason why, because, you know, when we get infection, as we were mentioning in the beginning, we have our own cells and immune system, adaptive immunity. Even if you are on rituximab, you have the T cell. And you should be able to have a little bit of memory. So yes, so it's like 4 months after the natural COVID infection.
Okay, I'm trying to screen the questions because there's a lot about the same theme, so we're trying to group the questions so we can answer all of them. Someone asked, and maybe we should take that one, about vaccination and the use of cyclophosphamide. So we talked a lot about rituximab. Let's mention.
Oh, it's the same thing for cyclophosphamide. It's as potent, I would say, as rituximab, and rituximab does work on B cells. Cyclophosphamide works on T cells and also B cells, so it's as potent as rituximab, probably is even more. So it's the same thing in terms of vaccination.
Okay, so there's kind of 3 or 4 questions here that is regarding the risk of having either a new diagnosis of vasculitis or a flare-up of the vasculitis after the vaccine. What's the concern with that? And you can take that one.
I think I'm interested in IgA vasculitis specifically and cutaneous vasculitis, and I think in the literature there are a few case reports and even series about de novo vasculitis or even reactivation in someone with already established diagnosis of vasculitis. We cannot ignore them, and of course they may happen, but this is not only something unique for COVID vaccine. These kind of disease also reported after influenza vaccine, after hepatitis vaccine. These are just like medication. So when we take some of the vasculitis, they might be triggered by medication, right? So, but I think in April of 2023, there was a report from Europe about comparing the COVID vaccine to the influenza vaccine in terms of activating vasculitis and de novo vasculitis, and so far there was no increased risk with COVID vaccine comparing to the influenza vaccine.
Okay, changing gears a little bit, there's an interesting question here about what's the recommended timing of COVID booster for caregivers living with vasculitis patients. Is there a different recommendation?
I'm not aware of different recommendation. It's the same. I mean, if they are healthy and they are not taking any immune suppressant, then it's going to apply the same as for any healthy individual. So
it will be the general recommendation for the general population. Mm-hmm. There are some questions here regarding what's in the future. Is there a new vaccine that is coming combined with the flu vaccine? And that's a great question. We all anxiously waiting for that. We don't have a final answer on that. There is a question about hepatitis B, whether before or after induction with rituximab, does it make any difference? What's the recommendation?
It's better to be giving before the infusion, but sometimes, if the disease is very, very severe, it's fine to be giving after.
And another interesting question, any tests to show response to COVID vaccine?
I'm not aware of.
Yeah.
I don't think
so. There is in the research world, however, not on a regular basis. In general, for pneumococcal vaccines, there is a way to test the general immune response to vaccines in general, but that's not applied specific to COVID. So the recommendation is to get the vaccine, but not test if you responded to the vaccine necessarily. The response is affected by the type of medication that the person is taking. Any problems with having shingles vaccine causing vasculitis? Or specifically here, the question PMR, but in general, that you are aware of?
I didn't come across that. I know a few cases after influenza, COVID, but I don't remember having things about hepatitis, no.
Yeah, the shingles vaccine, maybe you're referring to the first one, like the older one, when there was more fear and it was an attenuated virus, so it was not so safe as well as it is now the new one. So at that time we were concerned, and some of these vaccines were even contraindicated if you were immunosuppressed. But with the new vaccine, there's not this concern. So we did collect some data on our institution about COVID. I started doing that in March of 2020 on every single patient. And what I can tell about the COVID vaccine is there was not a major concern because the numbers were so low in terms of flaring up the vasculitis. However, there was a major concern with flaring up of the vasculitis or a new onset of vasculitis with the COVID infection itself. Those numbers were much higher.
I mean, going back to answer the question, I think in the literature so far, more cases reported after influenza vaccine and probably few cases after hepatitis, but I didn't come across any case of PMR reported after the vaccination. And of course, that study looked at the vasculitides, so I'm not certain if they looked at the PMR cases as well, but it was purely about vasculitis. And the most common one were cutaneous vasculitis and IgA vasculitis at that time. And I think it was in 2017 or 2019.
So good question here too. Is there a specific time period for immunocompromised patient to get the pneumococcal vaccine? So for example, they mention here the flu vaccine is given in the fall. Mm-hmm. How about the pneumococcal vaccine? Is there any specific recommendations?
Any time when they are due, but also I prefer in the fall as well. Even for me, when I'm going to consider the COVID vaccine for healthy individual, I say, okay, take it in the fall.
Yes, and for you guys, it's important to time with the medication. So if you're about to start a treatment for the immune-mediated disease, then the vaccine doesn't matter what time of the year. It should be given before mm-hmm. starting treatment if possible. So someone mentioned here that remdesivir is no longer available. That varies a lot from one hospital to another, but in general, the medication is still available as far as I know. Do you know anything about that?
Can you repeat the question?
If the remdesivir is no longer available, are you aware of anything?
As far as I know, it's still being given.
We have it in our hospital. Does anybody know if there's going to be a combination about with the flu? We're hoping so that we can give just a one shot. We don't have a final word on that. So research regarding relationship between COVID vaccine and causing vasculitis. So this question comes over and over and over again. Do you want to take that? And
I did address it earlier. I think one of the largest study mainly looked at IgA vasculitis because most of the de novo cases were reported about IgA vasculitis and about cutaneous vasculitis, and so far there was no increased concern with the COVID vaccine comparing to other medication or influenza vaccine in that trial. And by the way, they included almost 300 cases. So it was a very large study.
Okay, well, I hope that answers most of the questions, and this was very informative, and thank you so much for being here today.